Okay, hello everyone. This is Dr. Pruett. Today we're going to be talking about toxic ingestions. We've moved on from our trauma topics and are getting more into the medical and metabolic emergencies that we'll be facing. And this is fun for me because there's a little bit more pathophysiology involved. Starting off with overdoses, which is one of our more frequent calls that we see. While I was putting this together, I saw this quote online and I thought, the more I think about it, it's very, very true. That everything is a poison. There's nothing which is not. Only the dose is the difference between a poison and a remedy. So if we look at overdose deaths between 2002 and 2014, this is from the Department of Health and Human Services, overdose deaths have been increasing over time and are just getting worse. And if you look at our state statistics, our state, again, unfortunately, is one of the leading areas where overdose deaths are a very serious concern. And that's probably no surprise to us because we see so many 911 calls for these type of emergencies. And as we look a little bit closer at the epidemiology of overdoses, it makes sense that we kind of see a bimodal age distribution where 1 and 2 year olds tend to have toxic ingestions, mostly because this is at the phase where they're just becoming mobile and they're kind of putting everything they see into their mouth. Whether it's poison or whether it's not, we see a lot of toxicity in these very young children by accident. And then as people get older into their 20s, 30s, and 40s, there's another spike in toxic ingestions, and this time these are more intentional overdoses as an act of suicide or self-harm. So what happens, what's your first moves when you're dispatched to, say, a 30-year-old female overdose who took a handful of pills and is now unresponsive? Take a second to think about what you're going to do when you get there and what your priorities are going to be and how you're going to take good care of this patient. If I was dispatched to this call, again, vital signs are vital. I would get those quickly and get those first. Paying very close attention to her airway. Our ABCs are always a fantastic way to start. So airway, breathing, circulation. What's her mental status? Is she alert? Is she unresponsive? Quickly check a blood sugar as part of that set of vital signs. And then immediately get a 12 lead. As we get into some of the specifics about these overdoses, you'll see that a lot of them have cardiotoxic effects, and that 12 lead is going to tell you a lot about what you need to do next. Make sure you're closely monitoring these patients. Realize that they're probably going to get worse before they get better, so put them on capnography. That's a great clue to their what's going on at the cellular level, and keep a close eye on their blood pressure. I want to emphasize that you guys are at a very important point in this patient's story because you are the only ones in the medical chain of command who are going to have any access to the scene. And so you want to gather as much information as you can because realize that nobody else who's going to be taking care of her has access to as much information as you do regarding what happened to her. So you want to look around the room, see what substances might have been taken. Are there empty bottles? Are there other pill containers? Are there liquids, alcohol, needles, anything that you see that might be contributing to what's going on with your patient? Make sure you're gathering that and writing that down. Especially if the patient's unresponsive or they're uncooperative, you want to do your best to figure out exactly which pills they took, what kind of pills were they, how many, what was the dosage, what was the formulation, and really importantly is what time were these taken. That's going to help dictate some of the actions at the hospital and what modalities of treatment are available based on the time and type of ingestion. Don't forget that the Poison Center is an excellent resource for help in knowing what to look for, what to anticipate, and how to take really good care of this patient. So if you have extra hands on scene, I know it takes a little bit of time to make a phone call, but these guys can be really, really helpful, especially if you have a little bit longer transport time or extra time to take care of this patient on the way to the hospital. These guys can be very useful. Here's the phone number. I have it on speed dial in my phone just in case I need it. One very important thing to watch out for in these patients that have overdosed with a toxic ingestion is to keep a close eye on their respiratory status. Capnography is going to be incredibly important here. You're going to look for signs of hypoventilation and then signs of apnea on your capnography monitor. So hypoventilation is going to present with a decreased respiratory rate, so usually less than 10. And what you're going to see, at least initially, is climbing end tidal values. And what this means is that if you go back to your cellular physiology, cells just need 3 things to do their job. They need oxygen and sugar and red blood cells to deliver the oxygen, right? So they're still going to be metabolizing, and they're still going to be creating carbon dioxide as a byproduct. And so initially, those cells are still going to be doing their job because they're getting what they need, and those end tidal values of carbon dioxide are going to climb. But over time, as that patient is not breathing effectively and there's less oxygen delivery to the tissues, you'll start to see the end tidal drop off and become low, and the respiratory rate decrease. And either one of these situations where you see a decreased respiratory rate, either with a high end tidal or an end tidal that's dropping off, will likely need ventilation assistance with a BVM or a better established airway with a LMA or an ET tube. Some of these patients, depending on the drugs that they take, might actually be hyperventilating, and here you'll see an increased respiratory rate, maybe with a decreased end tidal, and that can indicate a pretty profound acidosis and the fact that cells are dying. So a couple areas that I can think of right away where you might see this would be maybe an aspirin overdose, or even a cyanide toxicity can cause the same kind of picture. Now, the patient's physical exam is going to give you some clues to what's going on. I'm not going to cover any of these toxidromes in depth today, but it's important to know that they do exist. Based on the class of medication and where that medication acts is going to really be manifested in what you see on exam. So it's very important to check your patient's mental status, their skin color. Is it flushed? Is it pale? Is it hot? Is it cool? What are their pupils like? I know you guys see this all the time with opiate overdoses and are quick to look at the pupils, and that's fantastic. But sometimes other things like, are their muscles rigid, or what are their secretions like, will also give you clues as to what medications they took and where the toxicity is occurring. And based on that, you can anticipate what treatments you're going to need. So fundamental to any understanding of physiology is just the 2 basic things of the parasympathetic system and the sympathetic system. Parasympathetic is your rest and digest. And so this is where there's no current threat, you're very relaxed, maybe laying in a hammock reading a book. Eyes are constricted because you can be focused, maybe reading on your book. Salivary glands, your stomach is working on digestion, your heart rate is low, your lungs are fairly constricted because you're not needing to breathe deeply. And basically the body's at rest and working on refueling itself for when it does need to be in action. The sympathetic nervous system, on the other hand, is what's activated by epinephrine or the adrenal glands. And this is where the fight or flight response occurs. And so in this instance, I always picture somebody maybe running from a bear. So pupils will be dilated. You don't need to see fine detail. All you need to do as you're running from that bear is make sure you don't run into a tree or trip over a rock, right? There's not going to be much salivation or digestion going on right now. All of that blood flow is going to be directed towards the large muscles to provide energy to run away from the bear. The lungs, the bronchi are going to be dilated, and the heart's going to be beating fast. So you're going to have a fast heart rate, a high blood pressure, dilated lungs to move lots of oxygen, to get oxygen to those muscles so you can get to safety. So sympathetic is running away from the bear. Parasympathetic is laying in a hammock reading a book. And this is important because a lot of the drugs we're going to talk about in a minute act on these different systems. One of the more common overdoses that we see is a Benadryl toxicity, and that's going to cause what's known as an anticholinergic toxidrome. And I just read that as anti-parasympathetic toxidrome. So what it does is it tips the scales more towards a sympathetic reaction. So you're going to have a patient who might be agitated and feel anxious. Their heart rate is going to be very fast. Their blood pressure is going to be high. They're going to have dilated pupils, and their mucous membranes are going to be very dry. Now, depending on the amount of toxicity, If it's severe, these patients might be so amped up on the sympathetic side that they might start to have seizures or arrhythmias. And those are the two things, if you have someone who is toxic on Benadryl, that I would be prepared to treat. Another common overdose is aspirin, and it's not always just aspirin. Some of our over-the-counter drugs are the most dangerous overdoses that we'll encounter. And aspirin can be hidden in a lot of formulations. The technical name for aspirin is acetylsalicylic acid, and that salicylate toxicity is what kills people. And it's hidden in BC powders, which are popular in the South for headache remedies that are in nearly every gas station, and people pop those things like candy. It's in Pepto-Bismol, and importantly here, in our population that likes to drink isopropyl alcohol in order to get drunk, there is a wintergreen flavoring that has methyl salicylate in it, which can cause the exact same toxicity as aspirin does. So if you have a patient who's intoxicated on essentially hand sanitizer, it's very important to note if that bottle is still around, whether or not it has methyl salicylate in it, because that patient very well might clinically appear intoxicated, but can have a very serious underlying toxicity occurring that you might not pick up on unless you are aware of exactly what they ingested. And all of these things are easily available over the counter. What happens in salicylate toxicity is that essentially ATP production slows down. Just like in cyanide toxicity, oxidative phosphorylation for the creation of ATP is stopped by the byproduct of aspirin and creates a very profound lactic acidosis. And so the symptoms that you'll get are altered mental status with an increased respiratory rate. Initially, you'll have tachycardia, and your patient will have a fever. Now, if you think about it, increased respiratory rate, increased heart rate, fever with altered mental status sounds exactly like sepsis. And that's what makes salicylate toxicity very dangerous, because unless you're thinking about it and considering it in a patient that doesn't have a really clear presentation, it's easy to think that this patient has sepsis when they might, in fact, have a toxic ingestion underlying their symptoms. Another very serious over-the-counter toxicity that we encounter fairly frequently is a Tylenol overdose. Tylenol is also called acetaminophen, and just like aspirin, it can be hidden in formulations of other drugs. One of the more common ones to think about, especially with our narcotic overdoses that we're facing, it's in Percocet, and it's in some formulations of prescription narcotics. So not only might these patients be overdosing on narcotic, it's important to think about a possible Tylenol overdose as well. And it is the main ingredient in NyQuil and some other cough and cold and flu formulations. Tylenol overdoses are actually the main cause of liver transplants and liver failure in our country, and these formulations are still available over the counter. Now, the toxic dose is 150 milligrams per kilogram, which is a significant amount of Tylenol, but realize that if that builds up over time, or even a one-time ingestion, this can be a fatal overdose. Here's what happens when Tylenol is digested by the body. It goes to the liver, and the toxic byproduct that Tylenol is degraded into is called NAPQI. And NAPQI is essentially a poison. But usually in small doses, less than 150 milligrams per kilogram, our body is able to digest NAPQI and turn it into glutathione, which is something that our kidneys and our liver recognize and can be easily metabolized. But at some point, the scales tip and too much NAPQI is produced by the massive doses of Tylenol, and we run out of glutathione, and then NAPQI causes cell death, and this is what leads to liver failure. So the antidote that we give in Tylenol overdoses is called N-acetylcysteine, and it actually has the word cysteine in its name, and it just provides a cofactor so that the liver has more ability to create glutathione and metabolize that toxic byproduct and help get the Tylenol out of the body. And if we can get the N-acetylcysteine into the body soon enough after the ingestion, the hope is that we can save the liver from cell death and from failure. Another very common overdose that we see in the pre-hospital setting is antihypertensives, whether that's beta blockers or calcium channel blockers. Now, these inherently are meant to decrease blood pressure, but if you take too much, you can easily anticipate that it might cause too low of a blood pressure, right? But beta blockers can also cause too low of a heart rate. They can affect blood sugar and make it go too low persistently. They can also cause seizures and arrhythmia. And the common theme with all of these overdoses is we're going to treat symptoms, and so you just need to know what to anticipate. So in these overdoses with beta blockers or calcium channel blockers, I would anticipate hypotension and bradycardia. For hypotension, we're going to give epinephrine. For bradycardia, if your patient is bradycardic, I would have atropine ready. If they're starting to have arrhythmic effects on the EKG, if they have a wide QRS, I would be ready to give bicarb. If it's a calcium channel overdose and the calcium channels are being blocked, it makes sense to give more calcium. So I'd have calcium ready depending on the type of drug. And then a very common side effect of both of these overdoses is hypoglycemia, and frequently these patients need to be on a drip to keep the correct amount of sugar in their blood and keep those cells doing what they need to do. These patients absolutely need to be on the cardiac monitor. We talked about anticipating bradycardia. I would not be surprised at all if you needed to pace or even to defibrillate, and I would be ready for that immediately. Another common overdose is Tri-Cyclic Antidepressants, and these get their name because they literally have 3 rings, tricyclic 3 rings, and that's based on their chemical structure. Some of the most common formulations are amitriptyline, nortriptyline, and then surprisingly, Flexeril, which is a pretty common drug that's prescribed for back pain, but it has the same chemical structure as some of the antidepressants in the same category. Now, what's dangerous about these is that at high doses, they have sodium channel blocking effects, but at lower doses, they have the same kind of toxidrome that Benadryl does. So it stops the parasympathetic system, which is rest and digest, and tilts the scales towards sympathetic activation. So you're going to have an agitated patient that has dilated pupils, a fast heart rate, is hot to the touch, sometimes to the point of being too hot, to the point that it could be heat stroke. They might have seizures, and they might have hypertensive emergency. There's a large effect on the muscle groups, and so they might have very rigid muscles or hyperreflexia. But the thing that's very dangerous with TCA overdoses is the cardiac toxicity. Because of the sodium channel blockade, this is what kills people in TCA overdoses. And so what you look for on your EKG is an idioventricular rhythm. So I don't want to get too deep into the physiology, but your P wave, which comes from the sinoatrial node, is started, that initial cardiac conduction is started when sodium channels open. So if you're blocking the sodium channels, you're not going to see a P wave. What you're going to see is an idioventricular rhythm. And as the sodium channels are blocked, what you're going to start to see is everything spreads out. So you're going to see a long QT, and you're going to see a wide QRS. And this is all because everything in the heart is based on the flow of ions, particularly sodium, potassium, and calcium. One of the diagnostic features of a TCA overdose is the tall terminal R wave in AVR too. So if you start to see a 12 lead that's looking more like a sine wave with everything looking prolonged and no P waves with a tall R wave in AVR, you need to think TCA toxicity. And the treatment for that, if you see the wide QRS, is going to be sodium bicarb. And this makes sense if you think about it, because TCAs are blocking the sodium channels. You want to give more sodium, and there's a large amount of sodium in sodium bicarb. So it's not the bicarb that's helping them, it's the sodium. These patients are also at risk for other arrhythmias, particularly as that QT widens. They might be at risk for torsades, and we know our treatment for that is magnesium. The brain is very sensitive to sodium channels as well, and if those are blocked, can lead to seizures. So be ready to treat seizures with benzos, particularly for SED. And these patients can also get hypotensive, so have your epinephrine ready too. Basically, we're basing our treatments on what problems the patient is presenting with. Another common overdose is antidepressants, SSRIs. These can cause serotonin syndrome. At mild overdoses, you're just going to see maybe an agitated patient that's sweating with a fast heart rate. But as they have larger amounts of ingestions, you're going to see worsening mental status, tachycardia, high blood pressure, high temperatures with delirium, hyperthermia, and muscle rigidity. Again, you're just going to treat what you see. So anticipate arrhythmias. If you see a wide QRS, give bicarb. Long QT with torsades, you want MAG. If they seize, you're going to treat with benzos. Be ready to treat that blood pressure and defibrillate if you need to. Lithium is another overdose. Again, you're just going to base your treatments on what you see. This can be acute or chronic based on the dose that the patient's taking. Frequently, if this is a bad enough overdose, these patients will end up on dialysis. Things that you're looking for with lithium toxicity are GI upset, so nausea, vomiting, diarrhea, which will make airway control a very big consideration with a vomiting and altered patient. Anticipate cardiac arrhythmias and maybe some neurological manifestations as well. I know that we frequently get called to patients who are huffing hydrocarbons in the parking lot or maybe gasoline, and then by the time we get there, they're awake and want to refuse care. Just realize that these patients are at risk for seizures, pulmonary edema, and dysrhythmia up to 24 hours after they're using these substances. There's not a lot we can do about it other than treat the symptoms that we see and explain these risks to the patient when they want to refuse. That there's been documented cases of patients dying up to 24 hours out of using these substances. At the beginning of this lecture, we mentioned the fact that young children are a large percentage of the population with unintentional ingestions. Pills that can kill these children just by having one pill are oral hypoglycemics, blood pressure medications, painkillers, TCAs and benzos, all the ones we just talked about, but realize it doesn't take a handful to hurt these kids. Sometimes it only takes one. And many times the story is they got into grandma's purse and got into the pills because they're different colors and they look like candy. So anytime you have an unresponsive child about the age of 1 or 2, make sure you're considering toxic ingestion in your differential and trying to gather information while you're there on scene. At the end of the day, toxic ingestions can be very complicated, but just remember, stick to your ABCs. Vital signs are vital. Make sure you're anticipating untoward events. Keep them on the monitor. Get a 12 lead. Anticipate seizures and anticipate hypoglycemia. Don't be afraid to call poison control if you need help. And that's all I have. If you have questions, feel free to talk to your 7-8 or reach out to me. I'm happy to talk about this too.